what I like to do and what I do in my research is to develop techniques that make the breast cancer treatment effective but easier to manage and has fewer associated long-term side effects. People within the same family share many of the same risk factors for disease, breast cancer being one of them. In the particular case of BRCA1 mutation, which is what Angelina Jolie has, that's a specific mutation that's associated with a specific outcome, which unfortunately is a significant increased risk of breast cancer, up to 87%. My recommendation as a cancer specialist is that women follow the American Cancer Society guidelines of screening yearly, beginning at the age of 40, if they're average risk. And if we can determine that they're high risk, sometimes we start as early as the age 35 or earlier based upon their personal and family history. A double mastectomy, I think, is a very reasonable option for someone who has a BRCA1 or 2 mutation. The initial part of the cancer management is guided by a breast surgeon or a breast surgical oncologist. That's a breast surgeon who manages breast cancer. Everyone can be reassured that Obamacare will cover hereditary gene testing, particularly for breast cancer, if the individual meets national guidelines for testing. The most important thing that a woman should know before undergoing breast cancer surgery is to remain calm. Once they hear the words, you have breast cancer, of course, there's an emotional response, there's fear, and there's a desire to want to react quickly to get it removed. But the reality is that most cancers have been present for a while before they were diagnosed, maybe even for years. And so acting quickly and rashly to rush to a treatment might rob you of a few opportunities that you might not otherwise have. The connection between breast and ovarian cancer largely has to do with the presence of a mutation that is common to both. There's BRCA1 breast cancer mutation, and there is BRCA2 breast cancer mutation. For BRCA1, the connection is that there's an 87% lifetime risk of breast cancer and a 40% lifetime risk of ovarian cancer. That's compared to a 13% and a less than 1% risk of those cancers. So it's markedly elevated. For BRCA2, the connection is that there's a 60% lifetime risk of breast cancer and a 25% lifetime risk of ovarian cancer, compared to a 13 and a 1% for those two cancers. So you can see that the presence of these mutations alone greatly amplify the risk of breast and ovarian cancer in mutation carriers. The main difference between Juliana Rancic and Jolie is that Juliana was diagnosed with breast cancer. In the case of Jolie, she did not have a diagnosis of breast cancer. She had a family history of cancer, in fact, ovarian cancer. But the diagnosis of ovarian cancer in her mother led her to undergo testing for genetic mutations. She was found to be BRCA1 positive, which increases the risk of breast and ovarian cancer, and she opted for prophylactic or preventive double mastectomy to reduce the chances of her having breast cancer in the future. Suzanne has been quite vocal on the topic, and it's important to know that although she chose some alternative medicines as a way to manage her breast cancer, she started off with standard therapy. Across the country, there's an effort to increase awareness about breast density. In fact, in the state of California, it's now law that women undergoing screening mammography must be informed about their breast density. Breast density is important because it not only increases the risk of breast cancer, but also makes breast cancer harder to detect. I have here an example of x-rays of the breast, called mammograms, and 4 different cheeses representing the 4 different levels of breast density. You have here what we call a holy cheese, one that has many holes, and that mirrors what we see in the case of level 1 breast density, where x-rays can pass very easily through the breast, and it produces an image that is relatively dark. On the other hand, more dense breasts have fewer holes, such as we see here at this end, and that's more like level 4 density, where the density of the cheese, or the breast, blocks the x-rays from reaching the mammogram. And so what you have here is a breast that's mostly white. Now, color is important because breast cancer, when it appears on the mammogram, appears white. And so as you can imagine, it's much more easy to find a breast cancer that is present on a dark background as opposed to a light background. Let me show you. Here's an example of a breast cancer that is found in what we call the fatty breast. Very easy to see from across the room. By comparison, what we have here is a breast cancer that's found in a dense breast. Much more difficult to find. Intraoperative radiotherapy, or what we call IORT for short, is a way of delivering that entire course of radiotherapy as a single treatment at the time of surgery. So we take the tumor out and we insert the radiotherapy device and treat the breast at that time. Once they're done with the radiation given during surgery, there's no need for additional radiotherapy after surgery. The device that we use for that is called an Intrabeam. What we do is we plug the unit into the wall outlet, and it converts electricity from a standard power outlet into X-rays that are emitted from the end of the device here. And what we do is we insert this device into the breast along with what we call an applicator, which goes over the end of the device, and then we can shape the breast tissue around this sphere. That makes sure that we can control how the radiation gets to the breast tissue. And over a course of 20 minutes or 30 minutes during surgery, we can deliver the entire course of radiation therapy while the patient is asleep. Over the last several years, I've been involved in a clinical trial that laid the foundation for the use of tumor freezing as a way of treating breast cancer. In the previous trial, we froze the cancers and then removed them just to prove that we can kill them completely. Now that we know we can now freeze the tumors and leave them in place. So in the office, I can use a device such as this called the cryoprobe, which is a needle-like device that freezes at the end. It freezes to minus 40 degrees using liquid nitrogen, and it can be inserted into the center of a tumor. The tumor and a rim of normal tissue around the tumor is frozen to the degree that it kills it. Over 20 to 30 minutes, that procedure can be completed. The device can be removed, and then over the next 6 to 12 months, the body will simply absorb the cancer that has been killed. So instead of removing the tumor, in this case, we're freezing it and leaving it in place so that the body can absorb it over time.